like to thank Julio for inviting me to speak. I have the unenviable task of talking about the ethical issues associated with the Cascade of Care. But coming from a background of bioethics, this is what I do on a regular basis. So ethical issues exist all along the Cascade of Care. And as new technologies and innovations are developed, such as treatment as prevention, new ethical issues arise. So in the 10 minutes, I obviously won't have time to talk about the ethical issues associated with each step along the cascade, but I will highlight a few ethical issues that I believe are particularly relevant to this session and this conference's focus. So the first ethical issue doesn't actually appear as a step along the cascade, but it's fundamental to the goal of an AIDS-free generation. And that ethical issue is, given this large pool of HIV uninfected individuals, how can we set priorities between prevention and treatment that maximizes utility without compromising ethical standards? So here we have to turn to the ethics of setting priorities. When resources are scarce, as they currently are, how do we decide how many resources should be allocated to prevention and how many resources should be allocated to treatment and moving people along the cascade? So setting these priorities obviously poses extremely difficult ethical challenges for formulating public health policy. And recent advances in HIV biomedical prevention illustrate the problem. So this is even truer today than it was just a few years ago because of new highly effective HIV prevention methods such as treatment as prevention and PrEP. Now, to illustrate some of the problems that you come across in making these allocation decisions, I'd like to examine just one element of prevention, which is the use of antiretroviral drugs. So there continues to be a shortage of antiretroviral drugs in many settings, and stockouts are still posing problems for treatment programs. So given that there are not enough drugs to reach all those who currently meet medical eligibility criteria for treatment, can we ethically divert some of those drugs to prevention? So there are a number of ethical principles that can be used when making these allocation decisions, but they can be weighed differently by different people, and they can sometimes conflict. So three of those ethical principles are utility, equity, and urgent need. Utility is probably the most widely used ethical principle in formulating public health policy, and it requires us to maximize benefits while minimizing harms. But what benefits should be counted? Should it be saving the most lives, maximizing health, or other non-health related benefits? Equity requires us to provide fairness in access to antiretroviral drugs, but how do we determine what is fair in the setting of treatment versus prevention? Do we prioritize those who are currently infected, or those who are uninfected but at high risk? Do we prioritize those who are the most vulnerable? What about those populations that have historically been marginalized? Lastly, we have the urgent need. And urgent need states that people's medical needs give rise to moral claims to healthcare resources. Now, in the context of allocating antiretroviral drugs for treatment versus prevention, urgent need takes on two different meanings. It can mean how soon deaths from non-treatment or non-prevention will occur, or it can mean how bad off people will be without treatment or a means of prevention. So, not surprisingly, people have interpreted and weighed these principles differently. So Ruth Macklin and I, in a recent article in Health Affairs, argued that given limited antiretroviral drugs, priority should first be given to treatment. Brock and Wickler, on the other hand, in an earlier article in the same journal, came to the exact opposite conclusion using many of the same ethical principles. So this is clearly an issue that's still open for debate. It actually was the focus of a recent UNAIDS consultation on the ethics of PrEP and early initiation of antiretroviral treatment for prevention, and I encourage you to look at that report. I'd also encourage you to take a look out this summer for a special issue of Developing World Bioethics, which is going to be entirely dedicated to this debate and go over it in much greater detail than I can here. So turning back to the treatment cascade, the next ethical issue I'd like to discuss is one that's been around since the earliest days of the HIV epidemic, and that's the ethics of HIV testing. So one of the questions with HIV testing is, how do we maximize the effectiveness of testing without compromising an individual's ability to choose to be tested? So this can be seen as a balance between utility on the one hand and autonomy on the other. And it's an old ethical debate, but one that is still highly relevant today because of changing HIV testing strategies. I mean, over time, we've moved from models that rely more on voluntary counseling and testing to models that are more provider-initiated testing and counseling. We've moved from opt-in consent to opt-out consent. And we moved from pre- and post-test risk-based assessment counseling to a more streamlined approach that provides pre-test information and, at least in HIV screening programs, referral for prevention counseling for those who test negative but are at high risk. So these changes are part of either the 2006 CDC HIV testing guidelines or the 2007 UNAIDS HIV testing guidelines. And to me and many others, they represent the end, or at least the beginning of the end of HIV exceptionalism in regard to testing. But of course, these changes have not come without ethical controversy. And many people actually frame this as a conflict between public health and human rights. But when you boil it down, the real concern is that using these new testing strategies might result in people being tested without their fully informed and voluntary consent. There was actually enough concern over this issue that for the first time the UNAIDS Reference Group on Human Rights publicly disagreed with some of the elements that were issued by, some of the elements in the HIV testing guidelines issued by the parent organization, UNAIDS. So, sorry, I'm going to go back for a second. So to me, as someone who does empiric work in bioethics, the interesting thing is that some of these ethical questions that surround HIV testing are actually amenable to empiric study. So we can formally test if people understand opt-out. We can even see if more people are tested without their knowledge using different testing strategies. But it doesn't really get at the main ethical question that's behind a lot of this, which is even if we show that people don't understand opt-out or may be more prone to be tested without their fully informed and voluntary consent, would these testing strategies still be considered ethically acceptable based on the public health benefits that come from increased testing? And that's an issue that is still open for debate. So moving a little bit further down on the treatment cascade, the next ethical issue I'd like to talk about is allocating scarce resources for treatment. So many of the same ethical principles that I talked about in allocating resources between prevention and treatment is applicable here as well. But the real issue with treatment is how do we ensure equitable access? And this is going to be even more of an issue as scale-up of treatment as prevention is scaled up and as medical eligibility criteria are changed. There's going to be a lot more people in need of drugs, and there may not be enough drugs. So the question I'd like to ask here is whether we need to use ethical principles at all in making allocation decisions about treatment. Norman Daniels, actually a very prominent bioethicist, advocates abandoning the idea that consensus decisions can be reached based on ethical principles alone. When making allocation decisions, he favors a more procedural approach that involves transparency, appeals to justifications that all can see as relevant to meeting healthcare needs, revisability, and enforcement. And to me, I think the key is whichever mechanism you use to make these allocation decisions on the local level, be it Daniel's fair processes or ethical analyses or some combination of both, the key is to avoid arbitrary or subjective or arbitrary criteria that may lead to discrimination against certain groups, and also to remember that no one allocation scheme obviously is going to work in every setting, such that different allocation schemes in different settings may be perfectly ethically appropriate. I'm actually going to skip this. This is a topic about using incentives for health promotion, something that's being studied in HPTN 065 and 068. And I believe Dr. El-Sadr is going to give some updates on this study tomorrow. So I just wanted to end by saying that, like everyone in this room, I believe that achieving AIDS-free generation is possible, but I think we need to keep ethics in mind when we make decisions about research, about prevention and treatment, and about allocation of resources. Thank you.